Hello and welcome to this session on perfecting your polypectomy technique. I'm joined in the studio by Christoph Schunians, Amir Klein, Lobke de Zomer, John Anderson, and we have Thomas Bottelberger joining us from Antwerp on the call. Welcome to everybody. We are going to combine a live case in this session, which Michael's going to do, with some cases, and we are going to start to cover different aspects of polypectomy. So let's go to the objectives. This is about the general approach to any colorectal polyp. John's going to talk about the 4 Ps, which are global tools to approach a colorectal polypectomy. Then we're going to talk, Christoph, about correct submucosal injection technique. I'm going to talk about snare placement technique, and then Nick Burgess from New Zealand is going to join us about how to assess a defect. We're going to describe the treatment of intraprocedural bleeding during polypectomy, and we're going to describe a best practice technique for managing perforations. So you might notice that that's all the components of the GPAT, and we will therefore later on in the day use the GPAT. If you don't know what the GPAT is, it's the global polypectomy assessment tool that we developed, and you'll find it just next to the toolbar where you're watching GIEQs right now. This is not what we want. This is not what we want. All right, without further ado, John, tell us about the 4 Ps.
Thank you, David. I do like a little bit of an acronym. If we could have the first slide, please. So I'm going to really take a general approach of and use some language. Roland was just talking about in the previous session language, and this is just really an overall approach to polypectomy. So where do you start? First, you've got to detect the lesion. And then you go through a phase of what I'm going to refer to as defining the lesion, which is really mapping the whole polyp in terms of its entirety and its junction between the polyp tissue and the normal mucosa. And in that process, that is part of an assessment process which detects what happens next. Your detection is largely dependent on your bowel prep, antispasmodics, distal tip, AI, etc. I'm not going to dwell too much on that. And then you have these 2 things. So as I say, define the borders and the morphology. And as we discussed this morning, you do a blink. Is the cancer there or not? Is the demarcation zone? So that's overt cancer. And then calculate the submucosal and invasive cancer. And then after you've done all of that, you can then select your technique. So the options you have are hot or cold, en bloc or piecemeal, lift or not lift. And then within that, you then need to select your accessories and then have a relevant diathermy setting. So in relation to technique, I'm going to discuss 4 Ps. So the first thing is having a plan. So having assessed the lesion, you then should have a plan of which technique you're going to use. And then once you've got your technique, you have to decide on how you're going to tackle the polyp. So if it's on block, that's fine. But in saying that, you think about where the patient is. So is the access to the polyp difficult? Is the polyp under a fluid pool? Do I need to change the patient position? You need a plan of which snare selection you're going to use, if it's hot or cold, and the size. And if you're using hot, you need your diathermy setting. So before you start off in your head, you should have a plan. And I would actually take that step 1 more. You should also have a plan B, because it doesn't always work. So before you start, you should have a good idea of what you're going to do. The position really refers to the patient position, the position of the accessory channel in relation to the polyp, the position of the polyp in relation to the tip of the scope, and the position of the snare in relation to both the polyp and the tip of the scope. So here we're going to optimize gravity and access. We're going to make sure the lesion is aligned to the scope channel. And for lower GI endoscopy, the channel is at 5 to 6 o'clock. You want everything nice and close. And we've seen today already, you need a cuff of normal tissue. And I want to get into your head, if you're doing a piecemeal resection, that you use the resection edge to progress. And I would suggest to you that the easiest way to do a resection is largely anal to oral, if you're in the forward viewing position. So you start at the front of the lesion and you work to the back of the lesion. Front to back, and you can move left to right within that plane, but you basically move front to back. If you're in the retroverted position, it works the other way. You go oral to anal because you're back to front. Optimal patient position. We've got a great session of this on GIEQs Online if you want to check this out. But whether you're going using water or whether you're going using air, when you come out, you're going to be using air in distension. And because you're using air in distension, we have optimal patient positions. And these will give you maximal distension and maximal visualization in the areas of the colon indicated there. So I'm going to leave that up. This is probably the most important thing if you're doing conscious sedation. You need to roll the patient in these positions to maximize your view. It will also help in terms of patient in the position. Positioning the polyp and moving the fluid. So as I said, the accessory channel is here. This is a schematic. The pair of eyes is your lights, and you tend to look down on your field of view. So when I speak to my trainees, I say it's like eating a plate of peas doing a polypectomy. If the polyp's off at sort of an angle, the peas are going to fall off the end of the plate, and you can't eat peas like that. It has to be flat, and it has to be right underneath you. And that way you maximize the visual field that you've got on top of the polyp, and you have control of the instrument. So in relation to the EMR technique, you want proximity. And what I mean by that is the distance between the tip of the instrument and the beginning of the lesion. And that enables you to place the V of the snare. And we talked about language. The V of the snare is really where you've got the catheter sheath and you've just got the snare coming out the catheter. So the snare is fully deployed, but you haven't got the extension. You've just got the V there. And that allows you to place the V very accurately down on top of the lesion. And I've put here a near focus. For those of you who've got this near focus button, even if you don't use it for interrogation, my tip is this: if you're placing a snare on a lesion and the near focus is on, everything should be in focus. If you're out of focus, you're too far away from the lesion to start the resection. So if you want to sense check, that's a way to do it. That's the distance I'm talking about. And then finally, the plane, ensuring that your snare is in the muscle, same parallel plane to the muscle, and you will minimize the risk of perforation. And you can use the snare to flatten the planes in benign lesions. Michael showed it with the biopsy forceps, and actually you can do it with the snare as well. But I would urge you not to cut across folds. If you're going to move across a fold, so you're actually on a hump of a fold, you need to align against the longitudinal axis of that fold. So you need to pivot the snare so you're going along with the muscle fibers. And this is what I mean. You want the plane between the lesion and the muscle there. And we talk about a couple of things. We talk about uphill and downhill. Uphill is 6 to 12 o'clock. And in this situation, the polyp is coming towards you. You can tend to put the snare, and the snare sits beautifully on the polyp. And the tip of the snare is on the top right panel is disappearing into the middle of the lumen. So there's no danger of you perforating, even if you can't see that bit of the snare. This is a really safe position for resection, and this is the easiest way to resect. When it's downhill, this is when you get incomplete resection, because the tip of your snare, firstly, is going deeper into the muscle there, not coming out of it, and secondly, you can't see this, and this is often where you leave a bit. You just chop the top off and you leave the rest of the polyp in situ. So if possible, you want to orientate it to get the polyp to 6 to 12 o'clock rather than running uphill rather than running downhill. And here's just a couple of examples of this. We want to be nice and close. We want a cuff of normal tissue. We push down. And after we close the snare, what we're going to do is, having pushed down to get the snare down, you're going to lift the tip up ever so slightly to make sure that the snare is in alignment with the muscle plane before you cut through. And we keep going. So, very basics. Have a plan. Think about your position. Think about the patient's position. Think about the position of the snare. The proximity to the lesion, the closer you are, the more control you've got. It's a physics thing. If you have a piece of straw and you hold it close, which is why we hold the pen near the end. If you try holding the pen at the top and try writing your name, your control of that is much less effective. You can do it while you're sitting at home. It's the same with the snare and your accessories. And then importantly, the plane is the thing that will protect you from perforation. Thank you.
Well, let's move right into Michael there.
Apparently mushrooms are in season.
Very nice. Show us the lesion. I saw it. It's quite small.
Okay. Yeah.
We have a 4-year-old
relaxing
patient with AFib, for which
sorry about that.
Asphyxiana, and diabetes, who has family history of colorectal cancer. Who was referred because of a positive screening test and had a colonoscopy recently, which shows these polyps. And so today they are assessed for resection.
Are we going to remove them?
Yeah.
Oh, very good.
That's
Okay.
why you're here. Yeah.
Okay, good. All right. Yeah, so you saw the 2 lesions. I had a look at the other one. Just in the interest of time, we'll look at we'll look at this one and remove it. The other one's also fine. Nothing to worry about. So it's sort of, it's a granular lesion, 2A morphology, sort of 2A1S really. We could do it by, it's on the cusp for cold. You know, it's a bit chunky to be done by cold, so it's going to be better to do it by hot. But we are sort of near the end of a randomized trial of hot versus cold for polyps between 15 and 40, and flat polyps between 15 and 40. This is not really flat because of that nodule. So we just have the needle, thanks.
Michael, can I ask you, does the presence of the diverticuli cause you any concerns or?
No, because I mean, it's a good question, but the polyp's not near the diverticuli. So, and cold snare excision is, it's amazing how uncommon it is that a polyp will be within a diverticulum.
Okay.
Don't you reckon? Like, who's seen a polyp within a diverticulum? It's really rare. But you still can resect them, but you've got to do it cold. So we don't commonly see polyps related to diverticuli for some reason. It's one of the great mysteries.
So, Michael, in this session, we got multiple, like 2 or 3 minute presentations on injection techniques, snare placement, Nick's joining for defect assessment. And we'd like to end with you doing the thermal ablation. So I wonder if you could just first take us through injection technique, and then we'll come back to you to do the next bit.
Okay, all right. So the first question is where to inject. So you can see that access is a little bit tricky to get right down to the cecum. So we've got to keep the gas down. It's always good to keep the gas down anyway. So to minimize the sort of stretching of the polyp on the colonic wall. And we want to maximize access by injection. So if I was to inject in the front here, it's definitely got to make things much more difficult. So I should inject in the back. So I ask Evie, to put the needle out for me. And then I drag back a little bit till I see the edge of the catheter, which is just going to appear just here, around about here. And now I'm going to inject, and we make a stab, inject, go. And we want to bring this polyp, so this is dynamic injection. I pull back a little bit, keep injecting, and I want to pull this polyp out of the cecum and into the ascending colon. Needle back. And now that we've done that first injection, I can even improve on it by making another one on this side. So same technique, I roll it out, needle out. Okay, I'm going to pull back a bit, and then I'm going to make a stab, inject, and I'm going to lift the polyp out of the cecum so that I can see the proximal margin. You see that?
Beautiful demonstration.
Keep going. Yep. Okay, so we really want to, normally stop there for a moment, Evie. We don't want to over-inject either. Normally if it's just in front of us, we just work sequentially away. But if it's hidden behind a fold, it's so much better to bring the polyp toward you unless you can retroflex behind the fold. Needle back. So now, what looked like a challenging resection with a sort of saddle distribution has become very easy. And it's always important to start in the most difficult area first. So we start on this side because for sure things don't get easier after injection. So we've got to resect that proximal side first.
Okay, Michael, we'll leave you for a second for a talk, and we'll come back to watch some snare placement technique in just a second.
Okay.
That's all right. All right, have the slides for Christophe, please.
Okay, thank you. Indeed, a beautiful demonstration of the injection technique. I'm going to go to a stepwise approach of the technique and the concept of dynamic injection. So why bother injecting? You want to better visualize a lesion, improve your access to facilitate resection, or maybe if it's a difficult lesion, maybe mark the lesion with injection to come back to it later if you're in a different position. Which needle can you use for injection doesn't really matter that much, the one you're comfortable working with. Of course, if you use a broad needle, then you can use it during the resection to do some blunt injection. Where to start injection, I wrote here, it depends a bit on the lesion, can be at the back of the front, as long as you get it to the submucosal plane. And if you can use your injection to get a better access, where we just had a beautiful demonstration of, that's of course a plus. Try to focus on a normal margin, so don't just inject the lesion, but also a bit of a normal tissue, especially if you're doing cold snare polypectomy. The orientation of your needle should be tangential to the wall. In the GIEQs, this can be a bit more difficult. Because you're in a perpendicular position then. If nothing happens after you start injecting, maybe the fluid is going to the peritoneal cavity. Always ask the nurse to start the injection before you insert the needle. And then, because of the dynamic injection, which we have some beautiful demonstrations of already, is you're going to stab through the mucosa, then pull back the needle until you're in the submucosa, and then you start to see the lesion lifting. And then use the needle to lift up the lesion into the mucosa. It would be up downwheel. How fast do you have to inject? Not too fast. It's better to inject slowly, and you want to avoid over injection because that might make the resection more difficult because your snare will slip off. If you think it might be a malignant lesion, I think it's important not to inject right through the lesion, but maybe use the margin stent because there's a theoretical risk of seeding. And then I think later on we're going to see some visual examples in the videos. And if you want to use the search button, then you just type in injection on the GIEQs Online site, and you can see many examples yourself.
Thanks, Christophe. Let's go back to Michael. He's just about to cut a piece off. Can we show the live?
Yeah.
Michael, you're back. But you've dropped a few points. I'm not going to lie, Michael, sorry.
Close slowly. Resistance.
John, is there any
This is the thing, I'm watching the snare, I'm not watching the screen.
So
I hope that's not a negative.
no, so I'm looking at this is not easy. So what's happening is, as Mike gives downward pressure with the snare, that pressure is pushing the skull back. And as he moves from the cecal pole back into the ascending colon, because the patient's in the right lateral, he goes underwater, he loses his view. And it's bowing just anteriorly. So it might be helpful, Mike, to get someone, when you're going for it with a snare to put the pressure down, just some epigastric pain, epigastric pressure, just to stop the transverse coming forward. Just when you're putting pressure on the scope, and it may just stop you pushing back into the ascending colon. It may not, but it might.
Yeah, we could do that, but I can do it without doing that. Because and the point I was making was, it's very important. So sometimes when it's very difficult, we get a red out, or you're under fluid or behind the fold. What you need to do is watch your assistant's hands, not the screen. So I wasn't watching the screen, I was watching Evie's hands, and I could see that she closed to resistance, and I had the snare in perfect position, so we didn't have to watch the snare close, just see it start to close, and then we get into this position like this. And now, then the next thing is, so now it looks like we might have a bit too much, maybe not. It's hard to tell.
What makes you think that, Michael? Is it
just the way it's bowing? Yeah. And so what I do is I release, and then I recapture. So I do all that myself. So watch again. So I bring the tissue towards me. I release a little, like so, and then I recapture. Okay, and that, if there is muscle in there, then we think, that should drop it out. And I feel happier now. Look, it moves much more freely. And then it's seated in straight away, so it should be fine.
There's an important point about snare closure there. I know some people close their own snare and some people have an assistant close it. But the key message is to reassess it and make sure you're happy before you actually go ahead.
So how to do that? So probably the best way is a fulcrum technique, open. So open a little bit. We do this with papillectomy all the time. Open, 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 push in. And then we can come down a little bit, close slowly, close, 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 close. Okay, good. And that should have it. Okay.
What do you mean by fulcrum technique, Michael?
Well, I missed it.
What would you stand? Why would that have
bottom
made
of the
it
class? Hey,
why would that have made it easy?
All right, we've got to make John Anderson happy. So, do you mind just pushing on the transverse colon for a tick?
So a good point, Manmeet. The language thing there, fulcrum technique, Michael. Is that pivot? Is that what you mean?
Pivot. Yeah.
Pivot. Yeah. Okay.
Yeah.
Is that more clear, Manmeet? Or are you still not sure what he means?
Do you know
Open
what a pivot is, Manmeet? Yeah.
Open.
Yeah.
Open.
So what?
Good.
So
Open,
just for
open.
the guys
Open
watching,
up.
if it sounds Irish or something to you, Michael's using the tip of the snare to basically embed, and it gives him a fixed point, which then allows him to push the catheter away from the point and flatten the snare into the same parallel plane to the muscle, which he's done before he closes.
Yeah, so we always have the generator. So first thing is to check the generator settings. So we should be on 80 watts effect. So we're not, right? So we have, at home, we have the generator set up.
Making Manmeet happy, Michael. By
there, soft coag, yep. So we check, and now the easiest way to do this, if we can just watch me on camera here, the easiest way to do it is to put your left hip against the bed, and then if you're like me and you have poor balance, you have your left hip against the bed, and then you just have your right foot above the blue pedal, and then you work with the scope and the snare as one. It's going to be a little bit tricky here because the access is not so great. See if I push in, hey, no, I think it's okay. So I'll start here, so tip out, thanks. So I'll start here, and you want to work in a linear way. So I'm going to just go straight up here. So.
And does it matter where you start, Mike?
No, it doesn't. No, not really. But it's certainly easier to go in a straight line.
Mm-hmm.
Yeah.
Okay. So that side's all done, and then
it's the same settings, but it's not the same effect.
And you've got to keep moving, and you've got to make sure that you treat the crevices, and you don't need to be worried about the extent of damage on the normal mucosa. That doesn't add any additional risk. And so we found in the open label study that NAS published of 1,600 resections like this, mean size 4 centimetre. That's a lot of polyps. David was involved as well, and Steve Heitman. We found that we could reduce recurrence to 1.4%. Can you believe that? 1.4% for those that had complete thermal ablation. So, if you're worried, you can extend the ablation zone well and truly out. You have to be sure you treat